Well, thank you all for coming out on this rainy Saturday morning, and thank you for being here. I am so honored to be doing this lecture in the name of Don Patey. And I'm especially honored because he is a giant of Canadian MS. Not only is he a giant around the world, but he is one of the fathers of MS in Canada. And as David was saying earlier, as we were chatting about Don, I never knew him. David knew him very well, but we Canadians need to stick together. And so thank you so much. I'm hoping I can get my slides up, if that's okay. I don't see my slides. Did I just advance it? Okay, sorry about that. That was my job and not yours. The original title of this was Pediatric MS 2024, which is kind of a nebulous title. And I want to tell you that what I'm going to be talking about today is pediatric onset MS, but what we've learned over the last 20 years. And in the spirit of Don Patey, I really want to say that, that the collaborative, the teamwork, the focus on care that permeates this organization, the CMSC, is really what I hope to relay through this. And the focus on all outcomes and how we work together in teams is, by the end of this lecture, I hope that I can relay in terms of pediatric onset MS. I'm going to be talking about progression and about emerging evidence on lifestyle interventions. These are my disclosures, and these are my objectives. I have 4 main objectives today. The first, and I'm sorry, I'm just going to ask the people at the desk one thing. Could you please turn the clock on so that I know how much time I have? I apologize, but nice to know how much time I have. Thank you. I'm going to talk about 4 things in particular. The first is to talk about what we've learned over the last 20 years or so. And I used to think about myself as just starting up. And only yesterday I woke up and I said, oh my goodness, I've been in this business, and my old friends, I've seen so many old friends that I've known for 10, 20 years and been working with for 10, 20 years. And I'm going to be talking about the things that we've learned together over the last 10 or 20 years about outcomes in pediatric onset MS. And then move on to talk about some factors that many of us have been thinking about that might influence those outcomes. I'll then move on to some of the work that we've been doing related to clinical trials and talk about the way that we've developed these clinical trials and some of our thoughts that have gone into them. And then talk finally about some challenges we faced and gaps in knowledge, which I hope we can approach together in the future. So I'll start off with a story and an MRI scan, which everyone in this room, I'm sure, would be comfortable in looking at and thinking about as we all care about MS and take care of MS. What's a little different in this is that this is a 14-year-old, not a 24-year-old. So this 14-year-old is a child who experienced some sensory abnormalities in the lower extremities, went back and forth to the emergency room, and started developing some motor difficulties, at which point she was put in a wheelchair and brought to the emergency room by her mother. The emergency room physician detected some abnormalities on motor and sensory testing and ordered an MRI scan of the brain and the spine. Now, everyone in this room would be comfortable in saying that this is a diagnosis of MS. And through the years, we've learned that MS occurs in kids and that we can make a diagnosis at first MRI. So that's not, for us right now, that's not the difficult case. But all of us who take care of children with MS and of anyone with MS know that when we are walking into that room and thinking and formulating our thoughts about what to say to families, what lays heavy on us is not how am I going to make the diagnosis, but what this means for the future. Because as we've seen in this conference, and we've known for many years, the problem is that of progressive injury. And this is a typical cartoon, which I borrowed from Ari Green a number of years ago, that demonstrates that we know in MS that there is a progressive course. This is like our mantra that we say in our sleep, those of us that take care of MS, that disability results down the line, and that our job is to understand what makes that disability come around. Well, how is the pediatric population difficult? What have we learned over the last 20 or so years about pediatric onset MS? And this is from early work, and I smile to think about what David was saying about Don Patey and sort of starting with MRI technology and about how much things have changed in many of our lifetimes in what we know about MS and about pediatric onset MS. And so when I was early on, and for those trainees out there, Jeff Cohen gave a talk in the mentorship forum, and he talked about thinking about one thing and really caring about it and sticking with it. So when I was very early on, about at the same stage as a lot of you, I became interested in pediatric onset MS with the help of a mentor, Bianca Weinstock-Gutman, and Robert Zvadnoff, and we asked the question of what happened down the line? Because what we observed in the clinical setting was that kids with MS seemed to have very high lesion loads. Was it that they were coming to us late? Why was it? Or was there some sort of immune dysfunction that led to the early onset of pediatric MS? And what we found in the observational work was that there was a higher lesion load in pediatric onset MS, and that there was greater atrophy through time in kids that eventually became adults and had MS for 20 years. This was demonstrated by many other groups as well. And what we knew was that kids, different from adults, the issue was not just atrophy, and this is work not from my group, but from the Canadian group before I went to Canada, led by Brenda Banwell and Doug Arnold, Louis Collins, who asked the question of what happens when you're a child and you have a hit? What is the longitudinal trajectory of your brain growth? Because as children, even in the teen years, there is ongoing brain development. There's pruning, there are changes in the brain structure which occur in healthy children. This graph, this three-panel graph, demonstrates the fall off in brain growth trajectory that was demonstrated from this work. And again, this is, it's important to note that the hit occurs early on in these kids. The blue and the coral-colored pictures demonstrate the healthy children that were part of the NIH cohort, and you see a nice trajectory that we usually see the sort of curvature this way. What you see in the next graph is a fall off, and you can see in the sort of darker color from here, it looks to me like it's a dark blue, a purplish blue, and a maroon. Those two darker ones at the bottom, those are the MS patients. And you can see that there is a drop-off in growth trajectory through time in boys and girls. And we always have to remember that there are different trajectories in boys versus girls. Later on, this is work from Julia Longoni at Sick Kids. She took the same data and asked the question about normal appearing white matter. And the black line is a healthy cohort, and the green line represents children with one hit, mono ADS as we call it, and the blue line demonstrates kids with MS. And you can see through time the x-axis is age in years, and you can see, similar to that whole brain volume question, that even if you have one hit, there is a drop-off in growth trajectory. But if you are a child with MS and have repeated hits, or the threat of repeated hits, that there is a further fall-off of developmental trajectory through time. What about vision? We know that as people interested in MS, that the eye is incredibly important and a window to the brain. And we've been interested in the eye for many years, since I was encouraged to think about these problems by my mentor, Bianca Weinstock-Gutman. And we looked at longitudinal visual metrics in kids with MS, knowing that retinal nerve fiber layer thickness and ganglion cell interplexiform thickness take a hit after one event in kids with MS. And we asked our question, the question of whether there was a longitudinal fall off that was similar to the fall off in brain growth and in normal appearing white matter. And in fact, what Dr. Langoni showed was that if you had more than one episode of optic neuritis, your fall off with your GCIPL and RNFL was dramatically different than if you had no episodes or one episode. So like the brain, like the normal appearing white matter, the eye, we can look at the eye and demonstrate that there's progressive change in kids with MS. So what does this mean for disability? Does it have implications for disability in kids with MS? We've been treating with off-label with DMTs for a number of years in pediatric onset MS. But this is a study which I continue to really think is very important, that was published in 2007 based on the pre-treatment era. And what it shows was very important and has been very important to me through the years that I've practiced, is that if you have childhood onset MS, that the time to irreversible disability is about 20 years, which is about twice as slow as in the adult population, where it's on an average about 8 years. But that if you are a child with MS, untreated, that the expectation is that you will have irreversible disability by the time you're 35 years or so. Now, that was a number of years ago for me, but it's not so for a lot of people in the audience. And if you think about 35 years of age, what that means, and to have MS from the time that you are developing independence, from the time you're a teenager, going to young adulthood, and then going into independence, that is an incredibly important developmental time for people. So this has always been a very important statistic that I keep in mind through time. But what about non-motor manifestations? We know now that there is progression in kids with MS and kids that become adults with MS. What happens with non-motor manifestations? And I think this is especially important in this particular audience, where we think about all of the aspects of care and outcome. What about cognition and psychosocial outcomes? Now, a number of people have been interested for many years in cognitive outcomes, including people, my own colleagues in Canada, colleagues in the UK and in the US. This is I think, a beautiful demonstration of something that we all know. We know at the bedside. But Kyla McKay, who's in Sweden, took the Swedish registry and asked the question of, after a number of years, what happens with cognition and how does that compare with adult onset MS in the pediatric population? And I don't know how well this projects, so I'm going to take you through this bit by bit. The top line on the left graph, which is sort of a taupey color, is the adult onset MS group. The bottom, the blue, is the pediatric onset MS group. The y-axis is SDMT scores, and the x-axis is age. And what you can see is a re-demonstration of the concept of progression and the rapidity of progression in kids with MS, such that once kids who then become adults, individuals who have pediatric onset MS, reach their 30s or 40s, their SDMT scores are in their boots, and they are far lower than adults of the same age. If you look at the graph on the right, you'll see that it's a different kind of graph, which demonstrates time rather than age on the x-axis, time since diagnosis versus SDMT score. And the important thing here that I want to highlight is that the steepness of that slope on the right, demonstrating a very rapid fall off at about 10 or 15 years after disease onset. So cognitive impairment runs with motor disability, and it is greater through time in pediatric onset MS with faster decline. What about other things? We know, as people who take care of people with MS, that it's not only the motor manifestations, it's cognition, and it's the outcomes like depression and fatigue. We've been interested in this for many years, and we and many other people have demonstrated high rates of depression, about 3 times that of healthy children, in the range of 30 to 50% in our population, and high levels of fatigue, which in some papers have been reported as high as 72%, 70% or so. We haven't found rates that high in our own population. It's more like 25 to 30%, but there's still higher rates than you see in the healthy population. So do depression and fatigue act in the same way that cognition and motor disability act? Now I want to highlight, this is a graph I'm going to show you later on, but this graph, I want you to focus only on the trajectory. This is work from Samantha Stevens, who's in the audience here, and who was a postdoc in my lab and now is a research associate. She does beautiful work. And what she demonstrated here, using our longitudinal data set with repeated measures of fatigue and depression, was that if you look at the pinkish line and the greenish lines, the green are kids with monophasic demyelinating disorders. So 1 episode, and they don't have any further episodes. And the pink are the MS patients. I'll talk to you about the double lines later on. But what I want to show you here is that with the fatigue scale that we use, the PEDS QOL fatigue scale, the lower the number, the worse the fatigue. And what Sam demonstrated here is that there is a fall off of fatigue scores, or worsening of fatigue scores through time in individuals with pediatric onset MS. And so the line on the bottom is time from diagnosis. She demonstrated the same thing with the same cohort in the depression questionnaires. Here in depression, the higher the number, the higher the depression score. And what we see here is that in MS, that there is, just like in that brain, go back and think about that brain graph of brain volumes, that there is a widening of the gulf between kids who have 1 episode and are otherwise well afterwards, and those with MS, in that there is a worsening of depression through time. So what I hope that you've seen so far is that, like the adult population, children with MS experience progression through time. And I want us all to remember, and I think we all know this anyway, but I just want to put it out there, that trajectory and that worsening is not just on motor abnormalities, it is on cognition, fatigue, and depression. And that the gap between adult onset MS and pediatric onset MS widens through time. And I suspect, we haven't looked at this in comparing the adult onset population with the pediatric onset population in depression and fatigue, but I suspect that given the trends that we saw in the pediatric population, that widens as well in children. So we know we know also, and what we've learned over the years in using medications that are approved in the adult population, that treatment matters. And that treatment matters, thinking back to that graph from the Renew paper that looked at disability, we know that from the Italian group and from many other groups, but this is just one demonstration, that we can predict outcome based on whether or not DMT are used. I think everyone in the room knows this and is convinced of this, but there is data that demonstrates this, observational, real-life, registry-based information, that relapse rate, recovery from our first episode and time to second episode, and the use of DMT matters. And I'm saying this, I don't have to convince you, but I have to spend a lot of time talking to families about this, convincing them, and we'll talk a little bit more about that in a second. What we also know, again, in using, because the RCT evidence that we have within the pediatric population for therapies is limited, and there is only one FDA-approved therapy and 2 approved by the EMA, that observational real-life data sets, large real-life data sets, combining data sets from across the world can help us to access more therapies and learn more about therapies. This is one demonstration of this from the large international, from the MS base group to get combined with the Italian group that did the paper that I just showed you. And this is a kind of complicated graph, but what I want to tell you is the bottom line from this paper was that not only did the Italian group previously demonstrate that any therapy makes a difference, which I think that we all are convinced of, but the use of high efficacy therapies early slows disability worsening. And the important message here was that DMT use was looked at in this paper as well, and any DMT made a difference in trajectory, thinking back to the trajectory. They didn't evaluate cognition, fatigue and depression, and so I think it's important to think about whether those run along parallel lines in the future. But I want to go back to the family and to that first picture that I showed you, and that scene of going into the emergency room or having a first patient visit with the teenager and family. Because for us as clinicians, it's easy for us to make the diagnosis. There is an incredible amount of guilt that families feel and bring to the clinic with them when they learn of these diagnoses. And in the rooms when discussing these things with families, there is also a fair degree of reluctance and I would say a need for growth of trust through time in the use of therapies, because people are going from having perfectly healthy children to having a child with a lifetime diagnosis. And it's very hard for many families to accept that a lifetime of therapy is what their children are destined for. And so the burning question for many families is, first, what did I do wrong? Which we work very hard on in our clinic to try to discuss and alleviate some of that guilt and that burden. It's incredibly traumatic for families. But also, on the flip side, the question is there something we can do other than medicine to change the trajectory? I want to share with you that we have not really published on this, but about 30 to 40% of our families want to wait to start therapy, despite all the evidence, despite my talking till I'm blue in the face that starting therapy early makes a difference. It is very, very challenging for families to accept this. And what they really want to know is, are there lifestyle factors that can have an effect on trajectory? Of course, all of us in the room, if anyone is involved in MS care, we've all been interested in this question for quite some time. And several people have looked at different aspects. I'll go through a few things really quickly because our main interest has been on physical activity, and that's where I'm going to concentrate the majority of the rest of what we'll talk about. But from the US group, Emmanuel Vauban has been asking this question for a number of years with her group, with the US group. And she and the US group administered questionnaires to families to ask the question of what aspects of diet might make a difference to disease activity, to the disease manifestations. And the two things that came out from these data were that vegetable intake, keeping in mind that it's really that not everybody is super honest about what they say that they ate in the last week, so keep that in mind. But that vegetable intake appeared to have an association with outcomes in MS, with the outcome of MS or no MS, and that saturated fat, increased amounts of saturated fat associate with higher relapse risk. This is a very complicated question that requires a lot of different, a lot of thinking about the different factors that go into diet and what other mechanisms might drive this. But it's a start. Obesity, of course, or BMI, something that we noticed very early on in our clinic population, seems to associate, and this has been shown very clearly in the adult population. What Annetta Langer-Gould showed about a decade ago was that the risk of MS in girls was higher, especially in those with a very high BMI, to the tune of about 4 times more likely. And this has been reproduced in other cohorts. But what we've been really interested in for the last decade or so, and we've had a number of partners in crime in this, is that of physical activity. Because from early on, we noticed in clinic that those kids that were involved in high levels of physical activity, and when I was in Buffalo, it was kids that were on state teams for things like volleyball and other sports, seemed to do much better. And so we set out, but there was this dichotomy in clinic, especially in Buffalo, with a number of different kids who we thought were not very active and had high BMIs, and then those that were the super athletes. So we set out first to ask the question of what is physical activity like in kids with MS, and to help us to answer the question of whether there are associations of physical activity with outcomes in pediatric onset MS. Now, how many of you know how much time a child should be spending, according to guidelines, and this is from Canadian guidelines, how much time a child should be spending per day on physical activity? Anyone out there? Okay, I'm going to tell you because I don't see a whole lot of, I see a few hands. Oh, someone's waving their hands way in the back. Amazing, and I bet Sam's waving her hand as well. But I'm going to tell you, and how many of you have kids or no kids? Have ever known a child? Okay, so the recommendation for children is an hour a day. And in the adult population, it's half an hour a day, so it's twice that of the adult population of moderate to vigorous physical activity. And and how many of you know kids that are getting that much physical activity? You probably know some very special kids if you are raising your hands, because in Canada, this grade is a D+, so this has been looked at in Canada, and only right now, after 2 decades of trying to get physical activity up, Canadian children have gone up from a D- grade to a D+ grade in physical activity. And only 35% of Canadian kids actually get the required amount of physical activity. We looked at kids with MS, and shockingly, the first thing that we learned was that they had almost 0 moderate to vigorous physical activity. So in comparison to their healthy counterparts who are already way below the recommended amounts, children with MS had lower amounts, and it was an amount that was so close to 0 that it was shocking to us. We went on to take those data and ask the question of whether there were associations between physical activity and brain metrics, structural metrics. And this is work done by Stephanie Grover, who is a research coordinator in my program now at the time. And what we found was that brain and lesion volumes associate with any moderate to vigorous physical activity. Forget that 60 minutes. What she looked at was whether or not we dichotomized kids, because there was such little physical activity, we dichotomized kids and asked the question, if you do any moderate to vigorous physical activity, do we see something different in the brain? And lo and behold, we were able to demonstrate that. Julia Longoni went on to look at a small population of our kids, because if you look at the literature on what exercise affects, it's the hippocampus, and the dentate gyrus in particular. And so she went on to ask the question of whether or not there were associations at the structural level in particular areas of the brain. And I'm showing you this because it, again, demonstrates the issue that we ran into. And if you look, the number of moderate to vigorous physical activity minutes per day is across the bottom. It's a little hard to see, but there are green and blue dots there. And what you'll see, the green dots are the MS patients. What you'll see is that all of the MS patients cluster at the bottom. You can see that there's only one patient in the MS group that actually falls into the 60 minutes per day group, whereas in the distribution is much better for those with monophasic demyelinating disorders. And so she was actually only able to demonstrate this association in non-MS patients, but we expect that it should be true in those with MS, and we need to do further work in looking at that. Structurally, what are the other places we can look? And if we go back to the eye, we can ask the question, because the eye, again, is a window to the brain, and any of you that went to the visual symposium that was held yesterday will remember the incredible utility that the OCT has for demonstrating the structural integrity of the retina. Well, what Jawera Ahmed, and I want to call Jawera and the CMSC out on this because she was a CMSC scholar, so I'm very grateful for the CMSC for allowing her to do this project or supporting this project. And what she found was that OCT metrics correlated strongly with whether or not kids had moderate to vigorous physical activity. Just like the work that you saw earlier, kids were dichotomized into high activity and low activity, and were demonstrated to have better OCT metrics if they fell into the high activity category. Now you might say, this is cross-sectional. It could be that kids with disability were more disability and worse disease were more likely to have lower physical activity. I want to remind you that the disability is very low in the kids that we take care of, but in fact we looked longitudinally, and this is Nahid Isias, who was another CMSC scholar who the next year went back and said, okay, we're going to look at this longitudinally and ask the same question. Does this hold out? If you are categorized as a child with high physical activity versus low physical activity, are there differences in outcomes? And this was demonstrated and supported in the data, which showed that moderate to vigorous physical activity associates with better OCT metrics through time. Okay, so what about psychosocial outcomes? I'm going back to this really nice work by Sam. And by the way, I just need to mention that Sam has been a driver of so many of these projects, that this is one that she was front and center on. And you'll see this graph again. And what I want to show you is that there are double lines. And you're not just seeing double, okay? There are double lines there. And what Sam did, like in these other projects, was she divided things between high activity and low activity. And the red represents, and I want you to remember this for the next graph, the red represents children with lower activity and the blue with higher activity. And what you can see here in the MS group is that through time, there is a persistence of poorer outcomes in fatigue and in depression in those with lower activity. But Sam took this a step further, because as clinicians, when we walk into a room, we don't want to just know, does it in general make a difference? But what do I need to do to move the needle? And in fact, what was incredible about this was that she found that in order to move the fatigue score or the depression score by what would be deemed a clinically relevant amount, it only took an extra 15 to 30 minutes of moderate to vigorous physical activity per week. Not per day, but per week. So it just takes a little bit. And thinking about the symposium, the wonderful symposium yesterday, where people were talking about, changing physical activity, I want you to remember in the pediatric population, at least, it looks like you can, just an incremental increase might make a huge difference to a child's life. Well, I think we all thought this was great, and we could take this and go to the clinic and say, I'm going to tell you what to do, child. And now, any of you that has dealt or ever known a teenager, if we write a prescription and say, hey, you got to change your physical activity because it's going to make a difference to you in 30 years or 20 years or 10 years, it goes like this over the child's head. And how many of you think that will lead to behavior change? Anyone's hands up? No? So using the framework of social cognitive theory, we ask the question of what can we do to sustain this? Because I think we've recognized that this is one of the biggest problems. We know all of these things, but how do we make this happen in the pediatric population? And what we found in our population was that exercise goal setting and physical activity self-efficacy were associated with vigorous physical activity, and more so than in the healthy control population, suggesting that we had a target, we had something that we could drive at in our intervention. With all of this information in mind, again, Sam has been at the center of this together with Rob Model and Marcia Finlayson in creating this app to think about how we can reach kids and change behavior. So we developed an app called the Atomic app, and it's really a program. And so, a lot of people have developed apps for lots of things. And on my phone, I must have like 200 apps. And I don't use very many of them. Well, why do I not use them? Because an app is just an app on the phone, and it really requires interaction. And so I want to emphasize it's an app with a program. And the program includes, our first attempt at it was a 12-week program, which looked at, which had coaching calls every month. And this is really just up, it's a busy slide, but I want to show you that we looked at step counts in relation to coaching calls and found that even in our feasibility study that there was anticipatory change in steps in relation to the Fitbit. In relation to coaching calls. And the other thing we saw was that there was quite a drop-off between the calls, and then at the end of the program, when kids knew that things were about to end, what you see there right at the end on the far right is that there's a major drop-off in activity. So the things we learned were maybe it takes more coaching calls, and maybe we should be doing a longer program. The other thing we learned from interviews was that coaching calls were a key ingredient, and when kids talked about the things that motivated them, that social connections and social support were essential. I'm going to highlight some work that Paul Yu did on a platform that he presented earlier this week, where he looked at physical activity and social network size, and he also looked at other parameters of social support, and also showed that social network, whether it's the size of your social network or certain aspects of the social network, associate with higher levels of physical activity. So all of these things were very important. These concepts are very important, couched in the overarching theory of social cognitive theory in developing the atomic intervention, which we've now fully recruited for. Now, I don't have the results for you yet, but I have some information that I'm going to show you later on that has given us pause during the trial. Okay? So what I've shown you so far is that there is progression in pediatric onset MS, probably worse than in the adult population, but there is a possibility of interventions that might change that trajectory. But what I want, and that we have started on that journey by trying to increase physical activity in children with MS. But what I want to remind you of is in those observational studies, we dichotomize kids between those with high activity and low activity. And if you look in the literature about physical activity, it really is moderate to vigorous physical activity that associates with brain health. There is a gap right now in mechanistic knowledge, especially in the pediatric population, but in the adult population with MS. This is a cartoon from a beautiful paper written by Wei Young and his group a few years ago that demonstrates the abundance of animal data that points to vigorous physical activity or exercise in association with a number of parameters that are relevant to MS, and this is using MS models. In the human space, it's more limited. And in particular, the knowledge about the biology of why exercise works to improve mood, cognition, or brain health is limited. A number of attempts have been made. The studies are small, and there are variable results. There's some promising work that focuses on BDNF and irisin, which we've been interested in for a couple of years now, and have paired up with a researcher in Alzheimer's who demonstrated reversibility of cognitive abnormalities in an Alzheimer's mouse model, which seems to be driven by irisin. But there is a need for further mechanistic knowledge related to exercise in MS, and that this needs to be accomplished through prospective randomized studies. And we need to do it together because the small studies, what we've learned from all of these studies is that the studies are small, limited, and have challenges related to their cohorts. We've started the study and would be very interested in collaborating with anyone that's interested in looking at these questions. So I'm going back to the atomic study in the last minute that I have, because I want to remind everyone that the kids that we take care of live in the context of society, of socio-demographic factors, and of all of the other things that we have learned to think more about in recent years. And this is what's given us pause. We are very worried about the kids that dropped out of our trial. So there are 4 sites for our study, sites A, B, C, and D. And if you look at the dropout rate, the last line on the graph, you can see that there is a huge difference between site A and site C and D in the dropout rate. Site C and D are urban. They're located in a different country from Site A, where there are greater health inequities and racial inequities. And I'm just bringing this up to ask the question of this, whether this reflects real life, and whether there are demographic factors that might drive the effect that we might have with the interventions that we're trying so hard to bring forward. We certainly have been interested in the question of how social factors shape biological outcomes, and remember that kids live in a large environment, and have started to ask this question, and this is from Sonika Kumari, who is a master's student in our group, and we're doing this together with many people, and in this was a poster that she brought to this year's CMSC. She evaluated neighborhoods and green space in kids with MS versus other kids without MS. And what she found, in kids with MS. And what she found was that when you have greater green space that's closer, you're more likely to have higher PA. And that you are 1.6 times more likely to be active. Now, this is pretty obvious, but I want to remind you that this cleaves along sociodemographic and socioeconomic lines, and we need to remember about equity factors, because our goal is really to try to give tailored care to individual patients, regardless of where they're from, and to remember all of those factors that drive outcomes. These are my conclusions and future directions, really, but I think that I've summarized them. We know that kids with MS have progressive disease, that there are lifestyle factors that can make a difference, but we need to pay attention to that continuum between biology, society, and the individual in order to provide better and more meaningful care to our patients. With that, I'd like to thank the organizers. I'm so delighted and honored to have been able to give this lecture. These are all of the team that I've been working with for many, many years, and this is a picture of our recent visit to the pottery, a pottery place where we did very important artwork as a team. And this is a picture of us here at the meeting. Thank you to the organizers for a wonderful meeting, and we're hopefully it projects okay. And this is the whole group of trainees that has come from Toronto to join the meeting, and they have told me that they love this meeting. It's their favorite meeting, so thank you to the organizers.
How's your mama, how you been? Girl, it's been too long. Sorry, sister, at the Circle K. Her baby number 2 is on the way. Hadn't seen her since her wedding day with you on my arm. It's good to hear from you again.